Hey guys, welcome back. This video today is interesting to me because it's a case where I really struggled with the treatment decisions, with the diagnosis, and with informing this patient of the right way to go, because it was a little bit unusual to me. It had a J-shaped lesion, which, we're all pretty familiar with those and what that usually means. But just the way that it all unfolded, kind of stuck with me and made me second guess myself a bit. And so I wanted to share it with you because I feel like we all kind of encounter these situations from time to time, and I hope it might be helpful. There is a little bit of surgical stuff in this video. I do go into a little bit of depth, a bit about extractions, so I hope that's helpful, but also there is some surgical stuff in here, so if that makes you uneasy, maybe just skip this video, but it's nothing too major. You can see this x-ray. This is how this tooth looked about 3 months ago. And then the patient came back to me 1 month ago and said, "Hey doc, that tooth on the bottom is hurting." And so I took a look at it and I was surprised to see this lesion at the apex. And I said, okay, wow. So the symptoms the patient was having were pain on biting. You could look at that and kind of interpret that x-ray in two different ways, right? You could say, well, it looks like just a run-of-the-mill periapical lesion from a necrotic pulp, or it could be some kind of vertical root fracture. We can almost look at it and see sort of that J-shaped lesion that we're taught in school means, the root is fractured vertically, and there's usually nothing that can be done to save the tooth other than obviously like a root amputation or extraction is usually the most preferred. I told the patient, I looked him in the eyes and I said, you know what, man, I can't tell if this tooth is fractured down to the root or if this is possibly just a necrotic tooth that needs a root canal. We won't truly know until we get in there and I look at the pulpal floor and see if there's a crack running through there. And I kind of chase that crack down the distal margin, down the distal aspect of the crown to the gingival margin, and see if it looks like it does in fact go below the gum line or if it stops at the gum line. And that was another thing I forgot to say, was that at the distal of number 31, over the distal marginal ridge and then heading down the distal aspect, there was a fracture line headed towards the gingiva, all the way to the gingiva. But, a lot of times when you get in there and you start to, chase that crack, a lot of times it'll stop at the gum level. And so I told the patient I didn't know how far it would go, but that I could see one. And so he was aware of that. And he said, okay, let's go ahead and do the root canal. And I trust you to make the decision, whatever it might be, whether we, end up needing to extract or if we're able to save the tooth. And I said, great, I feel the best about that. That's what I'd want for my tooth. And we'll just have you sign the consent forms for both options, and because we're going to be doing it with sedation. But if we get in there and we find that the tooth is non-restorable or, there is a vertical fracture, we'll just go ahead and extract it for you rather than waking you up from the sedation and then having to bring you back another time. He said, okay, that sounds good. And then, I see him on the schedule the next week to have it done. My office manager tells me, oh yeah, he decided he just wants to extract it. I was like, oh, really? I was like, that's kind of a bummer, but okay, like if that's really what he wants. So I talked to him a little bit about it when he came in. He said, yeah, doc, I just want to take it out. So we went ahead and anesthetized and just kind of did a routine, simple extraction. It wasn't very difficult. Used forceps and, started with a straight elevator to get a little bit of movement, and then forceps to kind of luxate it out the rest of the way. It was a non-surgical extraction. Now, I feel like this doesn't get pointed out enough, but when you're doing an extraction with forceps, you really need to make sure you're off of the lingual gingiva, because the worst thing you can do is grab some gingiva on the lingual with your forceps and then tear it or bruise it in some way. So you want to make sure you're getting kind of down into that flap with the forceps. And so you can see how easily that came out there because we'd already loosened it up. And now we're just using the Lucas curette to remove granulation tissue. And I spend a little bit of time doing this. I don't really rush it. I kind of scrape all the walls and just try to get down to the apex as long as it's not right on top of the nerve, because obviously I don't want to be scraping around down the nerve is. And then I flush with saline a little bit, just like this.
and get, I don't know, just kind of try to clear out any debris or any moisture from saliva that might have gotten down in there. Get any bacteria out there. And now I'm doing some pressure. I try to do it for about a minute. And that pressure on the alveolus with just your fingers has been shown to reduce postoperative pain. Just placing gauze. I just like to fold up half of a 4x4.
Made sure the patient had a good recovery from the sedation and sent him home. And after we sent him home, I went ahead and looked at the apex, and I was like, boy, I can't see a fracture there. I can't see any problem. So we started cutting, chase that crack down to the gingival margin area to see if I could see how far the crack went. And it stopped at kind of a supragingival area right at the dentoenamel junction, cemento-enamel junction, kind of in that area, CEJ. I didn't see any signs of it traveling below the gum line. So that kind of checks that box that, yeah, this should be a restorable tooth. But then I thought, well, let's go ahead and open the tooth up from the inside. Let's go ahead and act like we're doing a root canal on this tooth and look at the internal aspect of it to see if we can see any cracks running through the pulpal floor.
So as you can see, what I'm doing here is just inspecting the floor of the cavity prep. This is not the pulpal floor right now. This is just the floor of the preparation that was done. So we're still coronal to the pulpal floor. And, I didn't see any cracks there. So now I'm kind of going into the mesial box area and removing this composite. There was this big composite restoration here. And I'm just kind of taking that out. I want to see what's underneath it, see if there's any cracks off the mesial there that look like they might run through transversely. You can see that distal crack in the distal marginal ridge there opposite to where the handpiece is really, really clearly from this angle. And so I'm just kind of working in that mesial box right now. And so I'm removing this decay that was underneath that composite restoration on the mesial. And in a moment here, you'll be able to see more clearly once the camera comes into focus. But all the decay is removed and the margins are clean. And then I'm going to look here once right there. You can really see there's no cracks that are running through the mesial box to speak of there. But we still haven't gone down to the pulpal floor. We've still kind of been above that level. And now what I'm doing here is dropping through the floor of the box of the cavity preparation into the pulp chamber. And that's where I've dropped into that pulp chamber. It was kind of sclerosed a little bit, but it wasn't that hard to find. And we're looking down into the pulpal floor there at that view. Just doing some more work here. It's a lot of water, so it's kind of hard to see. But you can see the pulp chamber start to become de-roofed and start to become more obvious and apparent. And now what you can see there is a crack. Can you see that crack line? It's kind of near where my suction is. It comes across the distal marginal ridge. And right there, we just caught a glimpse of it for a second. You could see that crack line and the extent of it. And I just took a freeze frame right there. You can see that crack line. And you can see that it's pretty serious. And it does extend to the distal wall of the pulp chamber. But momentarily what we're going to see is that it doesn't actually extend through the pulpal floor completely. So this is very interesting. It's kind of a gray area in terms of restorability. What you can see I'm doing here is using my Explorer to just kind of feel along the floor of the pulp chamber and see if I can feel any cracks or see any or move some debris out of the way that might uncover a crack. And so I'm just feeling along that area really carefully. And you can see the crack to the distal, the same crack that we were looking at as it extended to the distal wall of the pulp chamber. It's a little fuzzy right there. It should be clear in a moment. We're getting that pulp out of the way from the distal root. And right there, you can see again, there's that crack on the distal that we'd been looking at. But there's no evidence that it actually went through the pulpal floor. I couldn't see it when I was looking with my loupes, and I can't see it on camera now either.
So I thought, well, let's do this. Let's go ahead and go down to the tip of the root and kind of start sectioning our way up, just lopping off segmental areas and seeing if we can see any signs of fracture. And in those cross sections that I did, I couldn't see any signs of fracture. Root canals, under the best of circumstances, are not 100% successful. There are plenty of times where everything should go completely right and it should heal up at the apex with no signs of pathology, and it doesn't for whatever reason. And so when you have a crack like this already pre-existing to any extent, we don't know exactly how far that crack went, but however far it went, it definitely is going to affect it negatively. It's not going to help anything. And so would this have been a savable root canal? I don't know. I don't know if this tooth would have had a good long-term prognosis or not. This is kind of on the line where that crack, it went halfway through. That crack may have gone through the distal portion of the distal root. In other words, if you're looking at the wall of the root canal space, the distal wall of the root canal may have had a crack through it. I couldn't see it, but that doesn't mean it's not there. At the end of the day, I think the best thing to do is to tell our patients what we can see, what we know, and what we don't know, and let them make the decision based off of the facts that we have. And that's what I tried to do in this scenario. I just gave my patient the facts and the unknowns, and then let him make the decision. So I think from that standpoint, it went about as well as it could have. But at the end of the day, we'll never really know. So thank you guys for watching, and we'll see you in the next one here in the interdental space.